So we are now going to transition to the point-counterpoint debate that we have resurrected at this year's meeting. I would like to introduce Dr. Wade Schrader, who is going to moderate this session. Dr. Wade Schrader is the Herbert Louis Endowed Chair of Pediatric Orthopedics at Phoenix Children's Hospital and the University of Arizona College of Medicine in Phoenix. He also serves as the medical director of the PCH Center for Cerebral Palsy and the Ping Bubba Watson Motion Analysis Laboratory. His research focus includes improvements in the quality of life, surgical outcomes, and pain assessment and control for children with cerebral palsy and other childhood onset neurodevelopmental disabilities. You've heard me speak nicely about Wade at this morning's plenary session. He has been a fabulous co-scientific program committee chair with Iona. Wade and his wife Carol, who you also heard speak at the parent panel, are the proud parents of 4 children, Benjamin and Mason, both of whom have cerebral palsy, and Claire and Kate. So I turn the podium over to you, Wade.
Thank you. Thank you, Darcy. So can we get my slides up there? Thank you. I don't want to take up much of our time because I really want to get into the rumble that we've got planned for you this afternoon. I'm excited to introduce our opponents for our point-counterpoint debate. And I'd like for them to just start heading on up to the podium because this won't take but just a minute to get started. So we're taking a contrasting viewpoint, and it's great to follow Gunnar's talk about whether we should be reactive versus more proactive in managing some of this early hip displacement in kids with CP. There we go. So I don't think either one of these gentlemen need much introduction to this audience and this academy. I both consider them my friends and mentors, and so I'm very proud to be able to introduce them and moderate this debate. Dr. Unni Narayanan, who's a pediatric orthopedic surgeon at the Hospital for Sick Kids, an associate professor at the Department of Surgery at the University of Toronto, is a senior scientist at the Bloorview Research Institute, and is our incoming second vice president of this academy. Professor Kerr is the University of Melbourne professor of orthopedic surgery and director of the Hugh Williamson Gait Laboratory and a consultant of pediatric orthopedic surgery at the Royal Children's Hospital in Melbourne. And both have had such incredible, meaningful contributions to the academy and the care of kids with CP that I'm anxious to hear this. And we're not advancing there. There we go. So we have 2 national heroes coming here to represent their countries, 2 great countries with Australia versus Canada. So I wanted to look a little bit at some of the other brief historical sporting contests between these two states. And so, of course, if we're going to talk about Canada, we got to talk about ice hockey. Australia does have a men's ice hockey team. I did have to do a little bit of research to find it. Their mascot is the Mighty Roos. Unfortunately, there have been 0 head-to-head games played against the Canadians. Australia did make it to the Olympics one year, and unfortunately, they did lose to the Americans, who were the gold medalists that year, and they lost 12-1 in actually 1960. And of course, the Canadians have a few medals in men's ice hockey with 9 gold medals, the most of any nation. There are the Canadians out there. However, on the rugby field, the Australians got their revenge. So you can see a listing of all the head-to-head contests between Australia and Canada, and there's some big lopsided victories in there for the Australians as well. So I am anxious to see how this today folds out, to see which country and which hero for that country prevails. And just to tee up the talk and to give a little bit of context, I'm going to show this case, which is very similar to what we've seen. This is a 4-year-old who's likely to be a GMFCS level 4, very spastic hip abduction, with limited range of motion with a migration of 35% on the right and 20% on the left. Our format is going to be very typical of debates where each opponent will have 15 minutes, then followed by a 5-minute rebuttal, and then we'll hopefully be able to open it up for questions. So, Professor, if you want to take the lead first.
Well, good afternoon, everyone. Thank you very much, Wade. Thank you, Unni. Thank you, Gunnar Haglund. That was just quite inspiring. I think we could make this really short. If it's a dead heat, we'll sing the national anthems, and ours is much better.
I think that sounds great.
But we could make it really, really short by saying, I agree with everything that Dr. Haglund has said. And Dr. Narayanan needs to get back to Toronto because his waiting list is too long, and there are yellow and red flashing lights that he needs to attend to. So these are my disclosures. I will be explaining why not to use botulinum toxin in the hips in children with cerebral palsy, but it's still a disclosure. In case it gets heated and I lose track, I want to give my acknowledgements now because, as Gunnar said, anything that we've done is by a large team. The two pillars of our team are the Victorian Cerebral Palsy Register, and our work is population-based because we have these wonderful people who have developed this register that help us to look at the population and not just those who come to the clinic. And the group who worked on the Australian hip surveillance guidelines, I will always be grateful to them for making our work more scientific. And a number of our previous fellows and current researchers are there, and I'm sure I've forgotten some, but these are key people, including several previous fellows here at this meeting and who are now well into their careers. So Professor Rosenbaum, who spoke this morning, has said that the plural of anecdote is not data. Dr. Narayanan comes from Toronto and is close to McMaster, and levels of evidence and data rules. So I do want to put out before you that we have been looking at some hard numbers, and although I'll definitely resort to word pictures and stories later, it is based on a few publications and looking at several hundred children, and some of them over many years. And I reckon the data here and elsewhere in the literature makes a compelling case for proactive management of the CP hip. There is, however, until recently, a major missing piece of the jigsaw that we've just recently tried to address. And it is this, that the relationship between hip morphology and pain has not been well established, and there are greatly conflicting ideas about this. We currently have a fellow finishing off work started by Ben Shore and Brendan Sue and Jason Howard and others, which will be presented when Dr. Narayanan comes as the guest of the Australian Orthopaedic Association to Melbourne next month, and we'll hear this paper along with other things. And I need to refer to that as new unpublished data. So, proactive hip management, in my mind, means this: a population-based surveillance, not just looking after the privileged few who come to your private clinic or your public hospital, but the whole population. Linked to a cerebral palsy register to detect early displacement, to treat early surgically when asymptomatic, and to avoid, as Gunnar has said, dislocation and salvage surgery. So, to set the context, some very quick points, and just to try to keep a train of thought. Who gets hip displacement? It's well known. Gunnar and I, these white-haired poor old guys with not much social life, were working on the same birth populations, 90, 91, and 92, in Sweden and in Melbourne at the same time. And you've just seen this slide, and our results are identical, which shows how wonderfully useful this GMFCS tool is. Thank you, Bob Palisano and all the colleagues. But those are our figures. They're exactly the same. Now, everybody knows that, and it also makes the point that you should never try to make more than one point in a paper, because nobody gets the second point. The second point is this, that the prevalence of hip displacement had nothing to do with the movement disorder. It was exactly the same if the child was spastic, dyskinetic, hypotonic, or mixed. That's really important because it tells us something very important about why you get hip displacement and probably how to treat it. So points number 3 and 4 tell us something about why. Why does it happen? So here's the brain with its injuries. Here's the upper motor neuron lesion. On this side, we have the positive features. And in these children, when you feel that adductor spasticity, when you feel the contractures, oh, you know that's got something big to do with it. Well, maybe not. Because down that side, the weakness and immobility we forget about, and we always ignore it. The positive is easy to feel, it's right there. The negative is easy to miss. I'm suggesting that not spasticity, but immobility is the major problem at GMFCS 4 and 5. And that plays out in the geometry of the proximal femur in this population-based study, which shows that the twist in the femur, the anteversion, and the neck shaft angle are related to immobility and lack of weight bearing. And so a hypotonic GMFCS 5 hip looks very like a spastic GMFCS 5 hip morphologically and on X-ray. Although the effects may be quite different, as Gunnar has said, spasticity may make it much more painful, but the geometry is quite similar. What are the effects? These are 3 wonderful young men from our long-term population-based study, all born in that birth cohort. One GMFCS2, who doesn't walk all that well, but he plays a wonderful round of golf. One GMFCS4, who's a great wheelchair athlete with good upper limbs. And one wonderful young man who's GMFCS5. So the effects of hip displacement are going to be different in these 3 functional groups, and it will always relate to pain as the #1 issue, but function comes close by, quality of life, and especially at GMFCS5, burden of care. So the missing piece in the jigsaw is, does this matter? Are they going to hurt? The literature says somewhere between 0 and 80%, as a fairly wide range of dislocated hips in cerebral palsy will hurt. In Melbourne, anecdotally, 100% of hips in GMFCS 2 and 3 kids, children who walk and talk, if they're displaced, the hips will hurt. We also think it's very high at GMFCS 4 and 5 when communication skills are good, but we don't know and we need the study. This is the new study. This is the unpublished data that will be getting off to publish as soon as possible. Is there a link between hip displacement and at skeletal maturity and hip morphology? The 3 tools that we applied were GMFCS to stratify the patients, our Melbourne hip classification system, and a simple pain scale. We actually had to revise our hip classification on the basis of this data because we discovered there were finer graduations of pain and hip displacement. So if you've got the old 6-level scale, borrowing from, again, our good friends who use this lovely term, expanded and revised, this is the new one, and it's in the Journal of Children's Orthopedics this year. I'm afraid I don't do well with iPhones and apps and computers, and so here are the 90 hip radiographs of the total of 103 patients with an MP of over 30% at skeletal maturity. And I needed to get them all on the floor, and I needed to line them up by GMFCS, and by unilateral versus bilateral, and by what age you had your operation. And it was just a big deck of playing cards, and I had to see them like this, although my young people did all the measurements on screen with proper tools in the proper way. But I had to do this. I'm very old-fashioned, and the trees come down to generate all the paper that I need. It's not 100% follow-up, but it's a 95% follow-up, 98 out of 103 adolescents. So here's one figure. Along the bottom horizontal axis is the hip grade. From 1 is normal to 6 is dislocated, 7 is salvage. And look at the relationship between the hip grade and the number of radiographs. So maybe X-raying hips actually keeps them in joint, and radiation treatment would be good. Well, not really. It's just a proxy measure for hip surveillance. And obviously, the poor kids with dislocated hips and salvage surgery had had no X-rays and no surveillance because, unlike Dr. Hagland, we have not yet managed to get this across the whole state. So kids missed out. This is the key slide. This is the median pain score by the hip morphology from 1 to 6 along the bottom. And you'll see from left to right, the pain scores rise as you go into worse hip morphology, but they also become incredibly variable. Everybody knows and everybody remembers that one kid was seen, and this is him right here, the 1 out of the 100, who had bilateral dislocations early, and still at age 20, his hips don't hurt a bit. But you better not count on that, because the median pain is up here with this very wide spread. This is pretty important. Taken to the statisticians, they told us to dichotomize the hip grades down the middle between 1 and 4 and 5 and 6, which equates to this line here or this line here. And statistically, that comes out as a very simple message that above that red line, pain scores are 0 or very low above the red line. Conversely, below the red line, median pain scores were very high, except for the occasional outlier below that line. Can hip displacement be prevented? Well, you know that we did 3 years of treatment in a randomized trial with botulinum toxin and a swash brace, and 3 years treatment we reported as our RCT, but equally important is the paper bottom right, which is the long-term follow-up published in Developmental Medicine. 3 years of treatment with botulinum toxin and the swash brace did not improve gross motor function. It did not prevent hip displacement. It did not reduce contractures. It did not reduce the need for surgery. That's the second paper. It did not reduce the complexity of the surgery. It did not improve hip morphology at maturity. The success rate of adductor surgery is better, but it's limited, as shown by this wonderful study by Ben Shore, which I won't have time to go into, but it shows that adductor surgery after about 3 years fails in a lot of the more involved kids. So our current approach in Melbourne is to move early bony reconstructive surgery into a preventive strategy, not a reconstructive strategy, because these femurs are so abnormal, they have to be made more normal. This is how we do it in very young children with varus derotation osteotomies, as described by Dr. Haglund. Dr. Narayanan will try to tell you that this is dangerous in young children, but we do have a growth plate surgery strategy to deal with that. We presented it in Poznan in 2010, and we took a firm decision not to try to publish it until we had 5-year follow-up. It's due out soon. Can dislocation be treated? Yes, it can. This is the large, complex surgery, bilateral soft tissue releases, bilateral femoral osteotomies, bilateral pelvic osteotomies, rarely needed in Sweden. But I point out one thing right there, that the hip at this time, having been dislocated, before it's put back in the joint, has already irreversible full thickness loss of cartilage. And that means, by definition, that hip cannot ever be as good as the hips that are treated early under the Swedish or Melbourne systems. So that hip can be put in joint, and it's much better than doing anything else, but it's not the best strategy. So here's the summary. Proactive versus reactive management. Proactive surgery, a la Sweden and Melbourne, avoids hip pain. There's an incredibly important work from Poznan by Dr. Joswiak and his colleagues that shows that high-grade subluxation and dislocation sensitizes the hip, upgrades pain, increases substance P, and it's very difficult to get on top of that when that's been going for a period of time. Proactive treatment reduces the burden of care, whereas late treatment with high-grade displacement increases the care burden. Very important paper, Young et al., group in Munster, Germany. There's the title, just recently published. A couple of very interesting co-authors, Shannon Weir and Unni Narayanan. My goodness me, you'd think you'd really want to keep the migration percentage down. Here are the other issues between proactive and reactive hip management. Avoid the cartilage loss that I've just shown you. Smaller, safer, more effective surgery, borne out by shorter hospital stay and almost never the need for a blood transfusion. But here's something too. We're the poor guys who have to do this work. Proactive surgery improves surgeons' sense of purpose and well-being. Salvage surgery, on the other hand, induces depression in these very sensitive orthopedic surgeons who need constant reinforcement and support of their colleagues in physiotherapy. So here is the message. Femoral heads from children. These are all excised femoral heads from 20 years ago in Melbourne, when hip dislocation was followed by intractable pain. This was last resort surgery, excision of the femoral head, completely unpredictable surgery, which is rarely effective. It's not used in any other diagnosis in childhood. It is not acceptable for typically developing children, and it's discrimination against children with cerebral palsy. Thank you.
All right, well, I'm anxious to hear how Unni responds to that. So we'll load his slides, please.
Thank you. I'll have you know, Wade, neither am I Canadian, nor is Kerr Australian.
But you're representing those countries.
Well,
though.
of course,
Yeah,
and very
right.
proudly. Okay. Disclosures, really none. On second thoughts, I am a surgeon. Surgeons get paid to operate, and surgeons get paid more when they operate more. So this is the patient that we were presented with, a 4-year-old child with bilateral spastic CP. I was told level 5, let's say level 4. Parents reported no symptoms, and I believed them. The migration percentage, 35% on the right, 20% on the left. Okay, the proposition before us, for hips that are at high risk for progressive displacement, a proactive surgical strategy, beautifully articulated, not once but twice already, is not superior to a reactive surgical strategy in the management of this child's hips, is the position I'm taking. Well, first you go to the dictionary. So proactive is defined as controlling a situation rather than just responding to it after it has happened, as opposed to reactive, where you're acting in response to a situation rather than controlling it. In a proactive approach, you prepare for or prevent possible future problems, whereas in reactive, you're responding to problems when they occur instead of doing something to prevent them. And I searched for a proverb, and there was a stitch in time saves 9 for proactive, and I could find nothing to support reactive. So I was in trouble. Then I looked for images, and not a single one for reactive. You know, it's all of these things. Now, this is who I'm debating, the Prof, as he's called by all the people he's taught. You know, if that isn't daunting enough, there's a second Prof who speaks before him. Okay? And these together are the prophets of proactive. Okay? Not a black hair in sight. Okay? So think of the wisdom. Yeah? They are the profs. I am merely an associate prof, and still have some black hair apparently. So clearly, I'm the straw man here. Kerr Graham would have you believe that I'm going to rush back tomorrow and then try and put this hip back in, or worse, lop it off altogether. Okay? But I'm here to tell you that reactive strategy or surgery is not synonymous with salvage surgery. Okay? So let's go back to why we're doing this in the first place. It's to prevent pain, or if there is pain, to relieve it. It's to preserve or restore a range of motion to facilitate ease of care, such as toileting, dressing, positioning, preventing skin problems. It's to preserve weight bearing for transfers, for exercise perhaps, and it's to preserve or restore quality of life. I think we can all agree that that is the ultimate goal. So if we use that as our context, proactive is a prophylactic strategy initiated prior to the onset of symptoms. Okay? And it aims to prevent contractures from interfering with care, or it prevents pain that interferes with quality of life, as opposed to a reactive approach, which is a strategy in response to symptoms, not 10 years later, but at the earliest onset of symptoms, with the aim of reducing or correcting contractures that are interfering with care, or to relieve pain that's interfering with quality of life. So that's the definition I'm going to use. Okay? So the proactive approach, as you've heard very well, is timing based on radiographs, the migration percentage. 35%, 30% in Melbourne, 40% perhaps in Sweden. Whereas the reactive approach is timing based on symptoms. And there's a question mark against it, because the symptom might come very early when the migration percentage isn't too bad, or the symptom might come a little bit later. But it's at the first onset of symptoms, and that's what we're fundamentally debating here. But if we took a step back and said, if we go back to the drawing board and define the ideal strategy, okay, I would say, yes, it will be preventive. Why should we ever allow symptoms to develop? It should be the least invasive way we can achieve that, to create the least discomfort, the easiest recovery with the fewest complications. It would be the most lasting, minimize the risk of recurrence and the need for repetition. It should be the most effective in achieving all those ultimate goals that I mentioned right at the beginning. And all things being equal, the least expensive. And the options that we have available at our disposal are serial Botox injections, soft tissue procedures, soft tissue plus bony procedures, and salvage procedures. And I would submit that no single treatment option listed above adequately meets all 5 of these ideal criteria. Okay? Hence, there's something to debate. Let's look at this graph. You've seen this before, described as identical to the Swedish experience. You clearly see where the action is. It's with level 4s and 5s, and perhaps about 40% of the level 3s. The likelihood of hip displacement, as defined, hip at risk at 30% increase with GMFCS level. Incontrovertible. So, the proactive strategy, operations for all hips at risk is better than reactive operation that's done later. Now, this conceptually might be true, except in 2 circumstances. If some hips at risk don't deteriorate, then you might be intervening unnecessarily for some. Or if, because you're taking a proactive approach, you're doing things very early, and the problem is in the brain, so all the reasons why this thing happened in the first place hasn't gone away, you are very likely to have to repeat that surgery, and often the bigger operation you were trying to avoid in the first place. So under those circumstances, a proactive approach may not necessarily be the most efficient. This was the graphical information from Gunnar Haglund's study that showed, again, the relationship of the risk of hip displacement relative to the GMFCS. Identical, they said, to each other, but are they? Well, you have to look at it upside down. It's in red. So 64% is the risk of 40% in level 5, 45% in level 4. Let's put these one on top of the other. So the top row is the percentage at risk of migration greater than percent by Gunnar Haglund's study. The second row is what was seen in Victoria, but there's a difference. And you subtract that consistently, the Melbourne study, the Victoria study, is 25% greater. Why is that? Merely because they defined a hip at risk by 10 percentage points different. One said 30%, one said 40%. So which is it? Because this has implications. You'd be operating on 25% more in Australia than you would be in Sweden based on these data. So variable definition of hips at risk has implications. We know from the very same paper that Gunnar Haglund published that hips with a migration percentage between 33% and 40%, 1/3 of these will resolve spontaneously without treatment. And indeed, they changed their guidelines in the CPUP surveillance. When introduced, a hip with migration percentage greater than 33% was a definition of a subluxated hip. Some hips do not need preventive surgery, and these hips should be regarded as hips at risk, needing intensified observation, etc. And they increased that threshold to greater than 40%. Okay? So, how about this issue of timing? The proactive approach is likely to be performed earlier. In younger kids, it's likely to require less invasive surgical strategies, perhaps soft tissue procedures alone. If the bone is added, there's less likelihood of adding a pelvic osteotomy. And it's more likely, we think, to require repeat operations, including bigger operations, perhaps. Whereas the reactive strategy is, by definition, being applied, on average, to older children. The operations are inevitably going to be larger, no question. And they, therefore, might be associated with a higher complication rate. Maybe they're less effective, but are they less likely to be repeated? And if too late, perhaps some hips will become unreconstructible. And that's, again, the crux of this debate. So does early soft tissue surgery prevent hip dislocation? Because that's that smaller, less invasive operation that's been adopted proactively, is suggested to be less invasive. Well, in this systematic review that Sue Stott published, the answer is not often. 2/3 of the time, these kids require a second operation or more, and these are the bigger operations. Maybe it improves range of motion, there may be reduction of pain and improved hygiene, but very little evidence for this because this was very poorly studied in these studies. This study was quoted and very quickly mentioned by Kerr, by Ben Shore and him. They looked at a 10-year series of primary adductor surgery, 330 children, mean age of 50 months, mean migration percent 43%, 85-month follow-up. Failure rate, look at the bottom. The total number of failures, 68%, with all the reasons for it above. They're all big operations, 161 of them, femoral vascular rotational osteotomies. Okay? The number of surgery survival, a mere 32%, identical to that systematic review that was done a few years earlier from the literature. When you look at the 4s and 5s, it is successful in less than 15% of the time for the 5s, less than 30% of the time for the level 4s. Okay? That's this patient that we were talking about here. Let's look at the Swedish literature. This was the study published by Gunnar Haglund. Got us all excited. 100% effective preventive strategy of hip dislocation, Sweden. The indications, migration percentage greater than 33%. They added bilateral adductor surgery, bony surgery when needed, and acetabular procedures occasionally. Okay? All right, let's drill deeper. Out of that cohort, only 50 children and 78 hips had a migration percentage greater than 33%, and this ranged up to 82%. 18 of these hips corrected spontaneously, another 11 decreased or stayed at 33% without any treatment. Okay? So only 11 had soft tissue surgery, 16 had VDROs, and 9 hips had spasticity managed by SDR or ITBs. They had no dislocations. I think that's incontrovertible. But many recurred, as you saw in Gunnar's presentation, and had or were waiting for additional surgery. So recommending proactive surgery is a bit like what we say about voting. You know, do it early and do it often. So if not surgery, what else? Okay? Remember this graph? You know, early on to spasticity management, casting perhaps, and then later on, your orthopedic interventions. Guess who? Another familiar name. Okay. Level 1 evidence. Randomized clinical trial, a great study, serial Botox and abduction orthosis versus controls, highly regarded and cited. What do they find? Serial Botox plus an abduction brace versus controls. These are quotes from the paper. A very small treatment benefit, a 2.6% increase per year in migration percentage in the treatment group compared to 5.7% change in the control group, which meant that lateral displacement continues to progress in the treatment group. Data do not support recommending treatment. Level 1 evidence, okay? But I read this paper. The primary outcome measure that was selected in the methods section for the sample size calculation was a migration percentage increase per year. Based on their own work, the expected migration percentage in controls by natural history was 6.4%. The selected effect size that they want to detect for their sample size calculations was a 50% reduction in migration percentage per year, which translates to 33.2% per year for an 80% power, etc. Okay? They required 44 in each group. They had that numbers. What did they find in the control group? Exactly what they predicted, a 5.7% change in migration percentage per year. How many progressed to surgery in 3 years? 50% of those patients. And the treatment group, 2.6% change in migration percentage per year. Yes, it continued to progress, but exactly how much they predicted, and that's what they want to detect. And progressed to surgery, half of the control group. They even said there's a strong effect in delaying progress to surgery. Botox injections and bracing may have been more effective in preventing the progression of contractures than in preventing hip displacement. From a parent's perspective, they look at that information and they're hearing Handel's Messiah. Hallelujah. I didn't hear any parent this morning say anything about migration percentage. Okay, so here's a case example of a reactive approach. A child, 3 years of age, migration percentage greater than 50%. I have recommended surgery, not symptomatic. Parents don't want it. We continue with Botox, 4 years, 6 years, 8.5 years. Now they're beginning to have some symptoms. A contracture interfering with care, not responding to Botox, a little bit of pain, wincing during care. We did our reconstructive approach and followed them out 2 years later. We continue to follow them. And responded well. So is there evidence for a reactive approach? In our efforts to validate and find out if our CP child questionnaire was responsive, we had a prospective longitudinal comparative cohort that looked at cases, operative group of 20, and a non-operative group comprising of patients on my dreadfully, shamefully long wait list, or those who declined surgery. Okay? They were identical in terms of age, demographic distribution, severity of hip displacement, but the cases, because I was selecting them well, were much more likely to have pain, and that's why they were getting their operations. Their CP child scores at baseline were identical for their total scores in every subscale except in the subscale of comfort and emotions when they were significantly more painful than the control group. We obviously succeeded in our operations, got the hips back in radiographically. When we looked at the mean change in CP child scores, in the controls, they stayed the same after 1 year or deteriorated, whereas in the cases, in total score, in personal care ADLs, in positioning, transfers, mobility, in comfort and emotions and behavior, and overall quality of life, they improved compared to the controls. And this was primarily a reactive strategy, and I'm not necessarily advocating for that necessarily, but there's some evidence that supports that it can work. So, the reactive is the way to boldly go.
Okay, we'll move now into our five-minute rebuttal. So, Professor.
Thank you, Unni. Thank you, Wade. So, it's really a shame when your own papers are quoted back to you and the initial writing was so poor that they've been so completely misunderstood. So proactive hip management is population-based surveillance linked to a register for the population to detect early displacement and to treat it early surgically when asymptomatic to avoid dislocation and salvage. If we continue to dabble, especially credible physicians and surgeons like Unni Narayanan with botulinum toxin, this is what happens. MJ, age 11, GMFCS4, early puberty. This would be 55% displacement, but a nice round femoral head, a less than 50-degree spinal curve. Easy for you, Wade, that spine? Easy, let's do it. Instead, chiropractic treatment and 3 6-month courses of Botox, 3 courses of Botox every 6 months for a total of 18 months. And now we have a 90-degree curve and a femoral head that looks on the right. Botulinum toxin engenders to many parents just enough improvement to get a sense of complacency and to dither and postpone surgery, which is the only definitive treatment, as Dr. Narayanan has just presented to you. So there is danger in continuing with the botulinum toxin strategy. When we started our work 20 years ago with botulinum toxin in the hip, this refers to the hip, not ambulant patients. And the graph was for ambulant patients that he just showed you. It was not for hips. He is again misquoting me. So this is what we hoped. Let's go for the really objective things. We hoped that botulinum toxin will improve gross motor function. It didn't. We hoped that it would prevent contractures. It delayed them a little, but it didn't prevent them. We hoped it would prevent hip dislocation. It didn't. And so what we're left with is all tip and no iceberg. And that's really not an effective treatment for a very progressive, difficult condition such as hip displacement in children with cerebral palsy. Finally, the anecdote. 2 children in our long-term follow-up study, 2 real, living, breathing children, Abir and Omar, migrant family, no English spoken at home, a genetic cerebral palsy, both GMFCS4, but good upper limb function and some quite good communication. Remarkably wonderful kids. They really have something very appealing about them. Abir presented at age 14 with painful, stiff, dislocated hips, a severe rash. Her mother said through an interpreter, her care is impossible, and these are her hips. By this stage, I looked at the surname and said, I think I know this family, but I'm not good at taking histories. This is Omar, age 16 years old. No pain, no limits to sitting time. Mother describes his care as easy. Look at his range of motion. Look at his sitting in the wheelchair. Then I looked back through the records, hip surveillance, referred by a pediatrician who has a little bit of confidence in her orthopedic colleagues, a simple orthopedic operation at age 3 years plus 2 months for the degree of displacement shown, one operation, 12-year follow-up, sitting comfortably in his wheelchair. This is an accidental randomized clinical trial with 2 subjects. The same CP, the same home care, an orthopedic surgeon who hadn't the time through an interpreter to take the family history, 2 different pediatricians. One is referred for early surgery, one is not. Abir's pain score at follow-up before salvage surgery was 7, her CP child score 36. Her brother, pain score 1, that's a 0 in terms of pain, that's where it was anchored, and a CP child score of 62. So thank you for listening. I believe that a population-based surveillance program to detect these problems at the earliest stage, to avoid severe displacement, to avoid dislocation and salvage surgery is absolutely crucial. I'm really grateful to Unni. I think this CP Child tool is wonderfully responsive, and is going to give us a lot of the information that we've been desperately seeking. In Melbourne, we're going to enroll in the international study that's being run out of Toronto, but we also feel that we're further along with the surgical strategies, and we've just enrolled our first patients for a randomized clinical trial comparing adductor surgery to VDROs for the younger child, and perhaps with both studies, we're going to learn a bit more in the next few years. Thank you for your attention.
This is a radiograph of a hip with osteoarthritis. Looks pretty bad. Would you consider prophylactic surgery based on radiographs? The analogy is a good one, because if you were 45 years old and had a hip like that, you'd be looking for anything you could to delay having that operation, because you knew that the hip replacement, which is one of the most effective surgical strategies in the armamentarium of a general orthopedic surgeon, only lasts that long, and there's a high chance that you have to repeat it. And I think we know someone with hip replacement. And I don't know about the other hip, but we would never consider there's a hip there. It's probably at risk for arthritis. So when you get back to this particular child, you really have to ask yourself, what is the most efficient, effective strategy? And there are really 2 reconstructive strategies, one which is prophylactic or proactive, and one which is reactive. And each has, I believe, certain pros and cons. But there is room for a hybrid approach. I don't think anyone in good faith, regardless of what you've heard today, can say that there's any evidence yet, not on basis of radiographs, not on the basis that the hip is dislocated or not, that a prophylactic surgery is superior. I'm not saying reactive surgery is superior to prophylactic. I'm just saying that there's no evidence yet that a prophylactic strategy is superior to reactive strategy. Perhaps there's room for a choice. It allows for the shared decision with parent and a caregiver. It buys time for the parents. It's not an urgent decision. Even I do recommend an operation for this particular child, because I tell them that in some centers, that's what they would get. So they should have that choice, and I'm willing to support that choice if they make it. And it isn't urgent. Even if they choose a prophylactic, early prophylactic approach, they don't have to decide today. They can do it over the next 6 months. That helps them become more comfortable with the surgeon, prepare for the operation beyond, and it buys time for the child. And if they choose a more early reactive strategy, it might buy time enough to reduce the likelihood of a second operation without compromising the ultimate goals. However, regardless of symptoms, my practice is to really push for surgery when the migration percentage starts to increase beyond 60 or 70%, because then I do believe our operations get more complicated and perhaps are associated with less effective outcomes. We all agree that this is something we don't want to happen. So a reactive approach is not an excuse to stop surveillance. It's not an excuse to make the recommendation when the migration percentage continues to go up. And I think if you follow those principles, you can still do it long before it gets to anywhere here, so that it becomes unreconstructible that we've got to do this salvage procedure. Which, by the way, while it doesn't work that great, does work better than nothing, leaving it like that if you are in that unfortunate situation. Mark Twain said, if you don't know where you are going, any road will get you there. Okay? So where do we want to go? Remember, there's a larger context here. That child we're talking about has lots of other things going on. Seizures, cognitive impairments, visual impairments. They're hearing impaired. They have difficulties communicating. They have reflux. They're aspirating. They're going to hospital. They're incontinent. And they've got these contractures and deformities of the trunk limb, which we as orthopedic surgeons tend to focus on, losing sight of that bigger picture. No wonder the parents are not so keen on the idea of a big operation, and they will do anything to try and avoid or delay it. And we have a strategy that will allow them, even if it's for 3 years, we could do an operation that maybe it makes it one operation less in the long run. Remember what our ultimate goals are and how we measure this. Now I think we do have a way that's reliable and valid and responsive to measure those important outcomes. And we have funding right now for this international multi-center study where we've involved 22 centers in 11 countries. It's an observational cohort design allowing nested trials looking at these 5 treatment groups using propensity scoring to try and adjust for various biases. We are just getting started, and we will be able to compare prophylactic versus reactive strategies, because we will be asking within the case report forms whether the child has symptoms at the time of the intervention or not. This was the first research study group at the Poznan meeting a year and a half ago, and I'm happy to say that both those profits are partners in this research enterprise. Thank you.
Bring my slides back up, please. So just to wrap this up, I think who is the winner in our debate today? Is it the professor? Is it our president? I think really it's very clear to say that it's really all the children that these physician scientists take care of and our academy. And I ask you to join with me again to thank both of them for what a great day and all the hard work they put into this.